All right, this week one of your classmates or groups of classmates did a thing on the kidneys, and they did a pretty good job of explaining how those kidneys work. So you really kind of have to know that. How do they clean the blood? What things would we expect to see in what's excreted? Okay, because whatever's excreted or put into your urine can determine how well the kidneys are functioning. So we look at that, and then how that blood flow works, what would affect that blood flow, because anything that affects that blood flow into the kidney or anything that affects the pressure in that glomerulus is going to affect your glomerular filtration rate, which is what? What is your glomerular filtration rate? What do you think? How many of you take a 24-hour urine before? Anybody?
Is it how well your kidneys filter out the waste?
Yes, it's determining how well your kidneys are filtering out the waste. So whenever we do one of these, okay, we'll get a jug. We'll throw out the first urine. Okay, we throw out the first urine because the first urine can be a little bit more concentrated, or could be like something that's just sitting in the bladder and it might not be accurate. And then we'll time it from that point. Okay. So usually starts in the morning time. So they wake up, we throw out the first urine, and then we start collecting the urine. All right. So in that kidney, we have this large artery that's bringing the blood into each kidney. There's little vessels that will branch off of those main arteries, and they go through those nephrons. Now, there's millions of those nephrons there. Okay. So they're all doing the same thing. Water, anything that's small like glucose, salts, amino acids, these are going to be forced out of the blood and into the nephrons. And as they go through the nephrons, most of the water and some of those nutrients are going to be put back into the blood vessels that go around the nephrons. There's also going to be waste material that's going to be left behind in those nephrons, and it's going to be cleaned. Okay, so the clean blood has a little bit less water, but a lot less waste. All right, and then it leaves the kidneys in a large vein. That large vein is called the renal vein, and that dumps back into your big veins, right? Your vena cava, superior and inferior vena cava, and it'll go back into circulation. The yellow fluid that leaves out of the nephrons is called urine. It leaves the kidneys through the ureters. It goes into the bladder and it's stored there. All right. And then it'll leave the body through the urethra. Urination is the process of actually getting rid of the urine from the body. Now, in the kidney, you have blood traveling from afferent arterioles to the capillaries in the nephron. That whole area is called the glomerulus. So there's a little picture of it there so you can see it. You can't see that with the eye because these are very tiny. The blood will leave out of the nephron through the efferent. So that's your exit artery. So you guys already know that. Afferent is incoming. That's bringing it into the glomerulus. And efferent is exit. So that's taking it back out. The blood goes from that efferent arteriole to what we call the pre or the peritubular capillaries and the vasa rector. Okay. So that's all here on these slides over here. Here's your pretubular capillaries. You notice they go around the outside here. You also have juxtaglomerular apparatus here. Your juxta cells, remember, I just call them juxta because it's hard to say that other word. But what are your juxta cells responsible for? Y'all know this because we talked about it. You just might not think about it when someone says it, but you know it. What are those juxta cells responsible for? Somebody take a stab at it. Just guess. If you don't know, if you get it wrong, so what? You get it
It's the
wrong now, you'll learn it
Perry.
for the exam, right?
is it to carry like fluids away from that area? Because juxta means like next to each other, right?
So your juxtaglomerular area is going to produce your renin. Those juxta cells produce renin. So
Okay.
whenever there's low flow, look at all those capillaries coming in there, right? Those arterioles and all. So if this area recognizes low flow, then that juxtaglomerular apparatus is going to trigger those juxta cells, which is going to actually trigger your renin. It's not
Okay,
something
so
they're going to test you on, okay, right now, but you'll see this over and over. And you'll see them when they talk about the RAS system, the renin, angiotensin, aldosterone system. That's what it is. Okay, they'll talk about the juxta cells. I just call them juxta. And I that name goes with nothing else that I'm aware of in the body. Okay?
I
That's
got
the only
another
place.
question.
Yes.
So just to make sure I'm understanding, the juxta is basically like a sensor or a monitor to make sure like when things are too low to,
Well, there's a
regulate it.
whole system working there together. Okay.
Okay, okay.
Yeah,
So it's
there's a
just the
whole
cog in the
system.
machine
But
basically.
when the kidneys recognize that there's low flow in, it is going to trigger at that juxta area because you have low flow. All these little red things here are arteries. And look at where they are all coming together here. And look at where your juxta is. So it is a sensor center in a sense. It is going to recognize here that we have low flow, and it is going to trigger renin from there.
All right, thank you.
Okay. And then that renin is going to trigger what?
Angiotensin plateau.
Yes. Angiotensin 1 or 2, which is going to trigger,
Vasoconstriction.
thank you, vasoconstriction. It's also going to cause us to release. The more you say this, the better off you'll be at it. It's going to cause us
Aldas-
to release what?
Aldosterone and
80.
ADH.
Aldosterone and ADH. And the aldosterone is going to help us hold on to more
Water and
Sodium
sodium.
and
Water and
water.
sodium.
water and sodium. That aldosterone comes from the adrenal cortex. Okay, that ADH comes from your PP gland, your posterior pituitary gland. And that's going to help us hold on to more
Water.
Water.
water. Now, when you look at this picture on the screen on the left, this box here represents your kidneys, okay? And all this is saying, and all that whole mess is saying is you have blood flow coming in here. This is your main renal artery. All these arteries here, they just supply the different lobes and the entire kidney. So it's flowing into here, it's going through here. Eventually, it's going to end up in this afferent or this incoming artery that's going to bring it into the glomerulus. That's your nephron there. Okay. Once the nephron does its job, then it's going to push it on through into the capillaries, from the capillaries into the veins, and back into the renal vein, which is the main kidney vein exiting the kidney. So you see them over here on the right. You have an artery coming in to feed the blood supply. And then once that blood's used and it needs to be oxygenated because all the nutrients have been removed from it, now it'll row back into that renal vein and go back into the inferior superior vena cava and back into the heart. Okay. So it can be reoxygenated. That's really mainly what you have to know. So you have a main artery coming in, and it's called the renal artery because it's coming into the kidney, right? Afferent incoming, supplying the nephron, bringing that nutrients, that blood to the nephron, bringing that waste there. Everything is removed. Once it gets in that nephron, it's either reabsorbed or excreted. Okay. Once that happens, then it goes out of the nephron into the renal vein and back into circulation. Things that don't go through that process are red blood cells and protein. Okay. They'll end up in the capillary membrane, but they are not going in and being part of that urine. If you see protein in there, if you see blood in that urine, then we have a problem with the kidney. It's not filtering the way it should be. So 3 things are happening in that nephron that help you form the urine. The filtration process, the reabsorption process, and the secretion process. So in the filtration process, okay, we have this protein-free plasma going from the glomerulus into the Bowman's capsule. All that's one piece. That's everything that's happening there is just part of cleaning that urine and getting the body ready for reabsorption and secretion. Okay. And then in reabsorption, we'll have certain substances that are going to go back into the bloodstream, basically. Okay. Secretion means it's going to be removed. So things like waste. Okay. Now, BUN and creatinine are the main things that look at kidney function. And if you think about it, why? Because those are telling us how much waste has been removed from the body. So, how is the body's concentration now? And so, when we look at that, it can tell us how well those kidneys are working. But if we look at the urine over a 24-hour period, then it gives us a little bit more information about what's being filtered versus what's not, and what rate is it being filtered at. And why do they look at that? Because if it's being filtered too slow, it can cause you to hold on to more waste. And if it's being filtered too fast, then it can cause you to get rid of things that your body may need to reabsorb. So, like, let's say in diabetic ketoacidosis, when they lose all that fluid, they're also losing sodium, electrolytes, a little bit of protein. They're losing a lot of things out of there. And so that's why when someone has diabetic ketoacidosis, before you can fix the metabolic issue, you have to give them fluids and fix the dehydration issue. So in those tubules, we have reabsorption of nutrients, water, and electrolytes, and then secretion of wastes. Hormones will control the reabsorption of the fluids and the electrolytes. The acid balance, or the pH of the blood, is also maintained here. Again, I try to break it down for you on the right so you can see what those kidneys are really doing during each one of these processes. So the major function of the tubules is reabsorption. And yesterday, when we were talking, or the other day, we talked about there's a couple different ways that can happen. One of them is through active transport. One is through osmosis. Okay. And then there's secretions that help with the urine formation. And those secretions can help without affecting the electrolyte balance of the body. During filtration, we'll have a large volume of fluid, waste, nutrients, electrolytes, other substances that are passing from the blood into the tubules. Remember, the red blood cells and the protein remain in the blood. When the filtration pressure increases, more filtrate forms. If you have protein and red blood cells in your blood, then you probably have a problem with your kidney. I don't expect them to ask you a lot of questions about the nephron, but you should understand how the nephron works. And because it's a little bit complicated in its structure, I try to give you simple slides here so that when you look at it, you can really understand what's happening. So really, if you look at the right, your renal artery, it's bringing in those nutrients, okay? And now your renal vein, that's leaving the kidney and taking the waste products and the oxygen back, okay? So like your carbon dioxide, that's going to go back to the lungs. Anything that else that's waste, like your nitrates and all that, that's going to leave the body in the form of urine. Any questions on any of that? So it's a number of things that are controlling that, as you can see. All right, your nephrons are in your cortex, and that's where the nephron tubules are. Okay, the nephrons perform the primary function of the kidneys. That's what they do: filter blood, reabsorb what the body needs, and excrete the rest as urine. So here you can see a really good picture of it. This is a much better picture, which shows you the incoming arterial, the exit. Okay, here's your glomerulus here, your loop of Henle. A lot of things take place in the loop of Henle. That's where your things like your diuretics, most of them work at, is in there. So just trying again to explain it over and over to make sure you understand what's happening here. Filtration, reabsorption, secretion, okay? Cells and protein remain in the blood and are not filtered into the urine unless there's damage or inflammation. Then we'll find blood and proteins like albumin. And really knowing that is going to help you also with some of those different disease processes of glomerulonephritis versus nephrotic syndrome. So your glomerular itself is going to have water, glucose, salts, and urea. That's your filtrate. Okay, so that's your urine. They'll call it glomerular filtrate, but it's really urine. And you know, nursing, they like to give a lot of big names for different things. So the fluid balance has to be maintained. All right, the adrenal cortex is regulating the sodium by releasing aldosterone to increase that sodium reabsorption. It also helps with water reabsorption and it helps excrete potassium. ADH, again, look, posterior pituitary gland. So that's why I call it the PP gland. Plus, it controls my PP. And I say that over and over so you can remember, but it only controls the water. Okay, so when it's released, it helps the kidneys reabsorb. And trying to remember, when would ADH, when would aldosterone be released? It's always going to be released when we don't have enough fluid, because both of these are going to help us hold more fluid. So whenever the body needs to conserve fluid, it's going to release aldosterone and ADH. So when would it need to conserve fluid? If there's some kind of low flow coming into the kidneys, it's going to try to do this process. If you're dehydrated, it's going to try to do this process. If your blood pressure is low, it's going to try to do this process. Because in any one of those situations, you have low flow coming into the kidneys. The kidneys are trying to protect itself and the body. So ADH, you have to know how that works in the body. All right. When you don't have enough water, like up here, I'm sorry, down here, when you don't have enough water, your content is low, more ADH is released. Why? Because ADH helps you reabsorb what?
Water.
Water. Okay. So because the ADH is released, it's anti-diuretic. And if it's anti-diuretic, it means you will not pee. Okay? You will not pee. More ADH, less pee, less urine, because it's making you reabsorb more water. So that's why if someone has SIADH, okay, syndrome of inappropriate antidiuretic hormone, they have too much ADH. And it's spelled SIADH. So I say too many letters equals too much ADH. Too much ADH, you're going to have more water reabsorbed and less urine going out. Anybody not understand that? Now, when there's too much water in the blood, okay, less ADH is released. So in diabetes insipidus, they don't have enough ADH. Less water is reabsorbed, and they're peeing. So we have to actually give them ADH, because otherwise they're going to have a problem with their fluid levels. These guys just lose water. But if you're losing a lot of water, then how's your blood going to be?
Decrease.
How's your salt in your blood going to be? Let me be more specific.
High
Is
concentration.
Water, how's your salt going to be?
Isn't it going to be a high concentration?
It's going to be saltier, right? So you could be hyper natremic here, okay? And also it's going to affect your osmotic pressure, right? Because it's going to make that saltier. And that has to be a little bit salty. Like, we want to be a little bit salty, but we don't want to be as salty as Karen. She's too salty. With the other one at the bottom, okay, we're holding more water. We're giving off less urine. So how's our salt going to be there? If we're holding more water, what's that going to do to the salt concentration?
Dilate
it. Okay. Also the osmotic pressure. So it's going to be less salty. And that can affect things in the body, right? When the osmotic pressure is low, it can cause us to hold on to fluid, because remember that osmotic pressure is help bringing fluid from the interstitial area back into the blood vessels. Aldosterone regulates that salt and water, and it's secreted by that adrenal cortex, and it helps us hold on to sodium and water through reabsorption. It also helps us get rid of potassium through the kidneys. So whenever we don't have enough fluid in the body, our blood pressure is low, the aldosterone is going to help us conserve more fluid. It's very closely linked to renin and angiotensinogen. Okay, so now you have that renin, angiotensinogen, aldosterone system. Normally, this just controls our blood pressure unless we have a problem in the body. Okay, so whenever there's low blood flow going into the kidneys, like a drop in the blood pressure, let's say someone had a bleed, okay, or something ruptured in the body and they're losing fluid. Now the body is going to trigger this system, okay? So it's going to trigger the RAS in general. Renin will be released first. That will cause the production of that angiotensinogen. That will cause vasoconstriction. Hopefully you're saying this with me. That will cause the release of aldosterone. Once the body reabsorbs the sodium in the water, the blood pressure goes back up, we restore all that, okay? Then the renin level is going to fall off and stop doing that. Oh, look, at the very top, renin is released from where? Those juxta cells. Okay, you have angiotensinogen 1 right here, okay? Angiotensinogen converting enzyme. That is where your ACE inhibitors work. It's supposed to block this process. Because if the angiotensinogen converts, what's going to happen to the blood pressure?
Pace goes up.
It's going to go up.
Yeah.
Okay. So when someone with high blood pressure, we're trying to stop that process. But if high blood pressure has damaged the kidneys or the arteries going into the kidneys and or something else in the body is causing the blood flow that's going into the kidney to be low, even if they have high blood pressure, it's going to trigger this process. Because high blood pressure doesn't equate to excess volume going into the organs always. Because the pressure is high, it doesn't always work right. So that's why you have that dangerous cycle of this low flow coming into the kidneys. And this is what people have in primary hypertension. Okay. They have low flow coming into the kidneys. It triggers this process. And then it raises the blood pressure. So it's like a vicious cycle. Okay. Once it's converted, the angiotensinogen, then it's going to trigger the release of that aldosterone. The angiotensinogen is going to cause the vasoconstriction. The aldosterone is going to cause us to reabsorb more sodium and water, and that is going to increase our blood pressure. So that renin is actually an enzyme, and it's sensitive to changes in the blood flow and the pressure. And it's made by special cells, those juxta cells, okay, part of the renin angiotensin aldosterone system. And the stimulus for renin is any decreased flow into the kidneys. It doesn't care why that flow is low. So that decreased blood flow into the kidneys could be caused, maybe you had diarrhea for a couple of days. So you lost sodium and water. Maybe you had vomiting. Maybe you were out working in excessive temperatures, in humid excessive temperatures, and you lost a lot of sweat. Maybe you had a bleed. Either way, it causes that renin because of that low flow to be produced. And that's going to cause the body to conserve. You see, it says on the right, conserve. All right. Any questions on that kidney? Or that RAS system? Or the difference between ADH and aldosterone? Where is it produced? You got it?
I think so. Yes.
All right. Next, we're going to talk about the parathyroid glands. Okay. Whenever you have low calcium in the body, the parathyroid gland controls phosphorus, vitamin D, regulates calcium. In the bones, it triggers the release of small amounts of calcium from the bones into the bloodstream. The kidneys help enable the activation of vitamin D, and they do that with help of the parathyroid hormone. The parathyroid hormone will also tell the kidneys to keep calcium in your body rather than excrete it. And in the small intestines, it will signal the small intestines to absorb more calcium from the food as we need it. Atrial natriuretic peptide. This is going to work when we have too much fluid in the heart, okay? That's why I call it the snitch bitch, because it goes down and it tells the kidneys, hey, stop it. We have too much fluid. Don't be sucking up anymore. All right, so it does that by reducing the sodium and the water. So it's going to inhibit what?
ADH.
Aldosterone, because we're talking about sodium and water. It will inhibit ADH too, but it's going to start with that aldosterone. Okay, so we have the fluid coming back into the heart that stretches the heart over here on the left. Okay, that causes the heart to secrete the atrial natriuretic peptide. Your book might call it hormone. It's the same thing. Okay, so this inhibits the reabsorption of sodium and water, and it does it in the tubules of the kidneys because that's where the reabsorption process takes place, right? So it's reducing the amount of aldosterone for the sodium and the water, and it also can inhibit the ADH. Ultimately, the atrial natriuretic peptide is going to reduce the sodium and water to decrease the blood pressure and lower the blood pressure. So it counteracts the angiotensin 2. It counteracts the aldosterone. It can cause an increase in the glomerular filtration rate. So remember, when the glomerular filtration rate increases, what happens?
Is the kidney working properly?
We'll have less reabsorption. Remember, if the glomerular filtrate rate increases, we'll have less reabsorption. If it decreases, we may retain stuff that we don't want. All right, so there are three things involved in the glomerular filtration rate: the pressure, the colloid pressure, which opposes filtration. So glomerular pressure increases filtration. The colloid pressure opposes filtration. And then in Bowman's capsule, we have hydrostatic pressure, which also opposes filtration. So these pressures are working against each other as we reabsorb and excrete different things in the kidney. And they can all affect the glomerular filtration rate. Okay, so hydrostatic pressure from the blood, remember that's your push pressure. Okay, that causes fluid from the blood to be filtered through that glomerulus. The amount of blood filtered through the glomeruli over a specific time is called the glomerular filtration rate. You have a lot of nephrons. Look how many. Up to 1.2 million. So blood can go through there pretty quick. All right, the blood is now ultra filtered. So it's minus the blood cells, minus the platelets, minus the large plasma proteins. It doesn't allow those things to go through there because they're large. So it sort of filters things out, like when you put the coffee filter in the pot, you put your grounds in, right? your coffee grounds, and then the water goes through there and you get coffee out, but you don't get the grounds. All right. So this is kind of like what your blood is, what your kidneys are doing with your blood. It's filtering out that large stuff and then taking what it needs, getting rid of the rest. So 3 things control the glomerular filtration rate. Autoregulation. This just happens naturally throughout the body. So anytime there's changes in the blood flow in your kidney, your body's going to adjust. And it does that by adjusting the size of the arterioles. So the diameter means, okay, the size of that arteriole. And if it vasoconstricts, what would happen to the diameter?
Decrease.
A smaller amount would be able to get through. If it vasodilates it, then it enlarges. Okay. So there's little changes that go on through the body all day in response to this blood flow going through your kidneys. Your sympathetic nervous system, that can cause vasoconstriction to both arteries. So now you may have low flow coming into the kidney. Okay, renin, secreted by those juxtaglomerular cells whenever the blood flow to the afferent arteriole is reduced. That is going to stimulate the renin, angiotensin, aldosterone system because it's trying to bring increased flow back into the kidney. That's what it's trying to do because it realizes that we don't have enough blood flow going out to the body. If the glomerular filtration rate is too high, then the substances that we need are not able to be reabsorbed and we lose them in the urine. If the filtration rate is too low, then everything is reabsorbed, including waste that we should be getting rid of. So the body is using mechanisms to control that, okay? Autoregulation, neural control, and your hormone, which is the renin, angiotensin, aldosterone system. Any vasoconstriction or dilation of the afferent arterioles will affect the rate of blood flow to the glomerulus, and that is going to affect the glomerular filtration rate. Again, we have the sympathetic nervous system, that's your neurocontrol, autoregulation. Those are all going to affect that rate. When the sympathetic nervous system is at rest, then your blood vessels going to the kidney are dilated. And autoregulation will kick in and work here. Under stress, okay, that sympathetic nervous system is going to kick in. Norepinephrine is going to be released. Epinephrine is going to be released. The afferent arterioles will constrict, and your ability to filtrate is then inhibited. And that also is going to stimulate the renin angiotensin mechanism. Any drop in the filtration pressure. So this means blood coming, flow coming into the kidney, okay? Any drop in that pressure coming in to the kidney is going to stimulate that juxta cells. And that's going to cause the body to release renin and erythropoietin. The glomerular filtration rate is the flow of the plasma from the glomerulus into the Bowman's space, or that nephron there. Okay. And that's how we look at kidney function. So this is just showing you here. If you have vasoconstriction here coming in from those afferent arterioles, it's going to decrease blood flow to the glomerulus. And that is going to ultimately decrease your glomerular filtration rate. If you have vasodilation in the afferent arterioles, then that is going to increase blood flow to the glomerulus. That will increase your glomerular filtration rate. So things that can decrease the glomerular filtration rate, okay? Kidney disease, diabetes and hypertension. Why? Why? Why do you think diabetes and hypertension can decrease the glomerular filtration rate? Come on, y'all notice we've been talking about it. What does it do to the vessels?
Because
More
both of them they cause damage to the kidney.
Yes, it's going to cause damage to the kidney, to those vessels going in there, just like it damages every other blood vessel in the body. Urinary tract obstruction, okay? You're not getting flow into the kidneys. It's backing up behind the kidney. Decreased renal flow, which I've said multiple times, you have low blood flow coming into the kidney, it's going to affect it. Or increased plasma proteins. Remember, we don't want proteins going into that area. A decrease in angiotensin too. So remember, I said they can take drugs like those ACE inhibitors that block that conversion. So that's going to decrease, okay, or block that whole formation there so that renin is not converted into that angiotensin to make that vasoconstriction. Or if you have increased sympathetic nervous system activity, causing the release of things like norepinephrine, that is going to cause vasoconstriction and decrease the flow into the afferent, okay, and decrease the glomerular filtration rate. Any questions on that? So sympathetic control of the glomerular filtration rate is aimed at long-term control of the blood pressure. Baroreceptors in your body will respond to any rapidly changing pressure in those arterioles. When the baroreceptors detect some sort of decrease in the blood pressure, then they'll signal the sympathetic nervous system activity. That will cause the vasoconstriction, decrease the glomerular filtration rate, and increase the blood pressure. So you see how all that's working together. Increased blood pressure will cause constriction of the afferent arteriole. Okay, whenever there's constriction in the afferent arteriole, what's that going to do to the glomerular filtration rate?
decrease.
Okay, good. A decrease in the blood pressure will dilate the afferent arteriole. And what's that going to do to the glomerular filtration rate? So remember, vasoconstriction will decrease the blood flow. Vasoconstriction in the afferent arteriole is going to decrease the blood flow into the glomerulars. That's going to decrease glomerular filtration rate. Vasodilation, that's going to happen in sympathetic nervous system, okay? Vasodilation will increase the blood flow. So vasodilation in the afferent arteriole will increase the blood flow and increase the glomerular filtration rate. Okay. This means we're putting less urine out. Okay. Up here, we're putting less urine out. Down here, we're putting more urine out. Okay, so that's all that's saying here. I want you to be able to read this and understand. If your blood pressure increases, it's going to cause constriction to that incoming arterial, and that's going to decrease the glomerular filtration rate so we can hold more fluid. All right. Alterations in renal function. So we can have obstruction, like calculi or some sort of tumor. An infection, like cystitis or pyelonephritis. So, what do you want to know from this? What can cause an obstruction? What would the obstruction lead to? What signs and symptoms would I see? What would cause cystitis? What would cause pyelonephritis? What would it look like? How do I know the difference between glomerulonephritis and pyelonephritis? Different causes. You should know the cause for each one. You should know what each one looks like symptomatically. When your client presents, what are they going to look like? What's the difference between acute renal failure and chronic renal failure? And signs and symptoms are going to be different from those also. You need to know it. All right, so micturition, that's just the flow of that urine. Okay, in the bladder, you have a detrusor muscle. Okay, and it will contract so that the urine can empty out of the bladder. There's pressure there, okay? The triangular section outlined by the three openings in that bladder is called the trizone. I would know that. Right? So the bladder's like a balloon. It has that smooth muscle. Remember, I always talk about smooth muscle. I say wherever there's smooth muscle, there's going to be what?
Constrict.
Some sort of action, right? In this case, we're going to have contraction of that detrusor muscle, and that allows the urine to flow out. You need to know these. And I don't know. Okay, this one looks right. Some of my slides on this one got messed up, but let's see if these ones are right. So when it comes to incontinence, okay, first of all, you need to know what actual incontinence is. And incontinence itself is losing control of the bladder. And a lot of people have this issue, okay, or they wouldn't sell all those adult products. Now, stress incontinence is more common in women. Why do you think?
Pregnancy.
Yeah, I mean, men don't go through that, giving birth to a bowling ball. And women do a lot of lifting as well in the house. Okay. They'll move furniture, they move refrigerators, they lift kids, they do a lot of lifting. Okay. We don't always wait for you guys to come home. So while you're out lifting at work, we're lifting at home. So stress incontinence, the cause is increased intra-abdominal pressure. It forces the urine through the sphincter. Okay. So you just went in the bathroom and you peed, right? Now, 20 minutes later, you're sitting in the living room and you're watching a comedy show and you start laughing or you sneeze because there's some sort of allergy in the air. And next thing you know, you feel this little wetness in your lap. Okay? But you don't understand it because you just urinated. Some of that urine, okay, especially in stress incontinence, It's not leaving. Not all the urine is leaving out of that bladder. This can be also from weak abdominal muscles. Okay. So that's why multiple pregnancies really can affect this. Overflow incontinence is from an incompetent bladder. So for these clients, they have a weak detrusor muscle. Why is that a problem? How does urination work? We just said it. How does urination work? What happens with the detrusor muscle?
Releases.
Constrict and release.
Contracts. Okay, so if it's weak, it may have a weak contraction. And that prevents complete emptying of the bladder. So stress incontinence is increased abdominal pressure. Overflow incontinence is incompetent bladder with a weak detrusor muscle that prevents complete emptying. Just incontinence itself, any kind of incontinence, is when you've lost voluntary control of the bladder. And enuresis is involuntary urination by a child over the age of 4. A lot of times this will happen when they sleep. It's related to developmental delays or some other issue. When people retain urine, they're not able to completely empty the bladder. So we will see that in overflow incontinence. Also, if someone has a spinal cord injury, it can block the reflex for you to urinate. And that can cause you to retain urine. Urine retention can happen when someone gets anesthesia. Someone can also have a spinal cord injury. That can cause a neurogenic bladder, where the bladder itself is spastic or flaccid. And this is from damage to the central nervous system and the autonomic system. These clients may need a suprapubic tube. So this bladder will spasm all the time and it doesn't work right. They can no longer control the sphincters to urinate. So you'll see this in stroke patients, spinal cord injury, after the use of spinal blocks and narcotics. You have to know the difference between hemodialysis and peritoneal dialysis. Okay? Hemodialysis, usually 3 to 4 times a week, lasts about 3 to 4 hours each time. The complications for this are infected shunt. Remember, the shunt is where you're actually putting that blood through. Or that dialysate. Blood clots can form. The blood vessels themselves can become sclerosed or damaged. Usually, if that happens, they have to change the site. Increased risk for infection with Hep B, Hep C, or HIV. That's your hemodialysis. And you have to know the difference. Peritoneal is usually done outpatient. We use the peritoneal membrane to do the exchange with. It takes longer than hemodialysis. So usually they do it overnight while they're sleeping. The major complication for this is peritonitis, which is an infection. You may see prophylactic antibiotics given with either one. Both can get infections, okay? It's going to be different types of infection. So with hemo, we're looking at the shunt usually. With peritoneal, we're looking at peritonitis usually. And we have to be careful, okay? Because things can build up in these clients.
Ms. Loesch,
Yes.
the hemodialysis saying that is required 3 times a week. How often is the peritoneal dialysis required?
You know what? That's a good question. They do it overnight. Let me see if I can get you an answer for that. I don't think they do it daily because that would probably.
Actually, where I work, they do it daily, but I
Do
don't
they?
know if that's normal per home. Yeah, the
They do
hospital I work in, we do
peritoneal
it
there
daily.
or hemodialysis?
We do PD on the floor, and there's a dialysis center there, but they do PD daily, sometimes a couple times a day,
Okay.
because it's
So it
manual.
probably depends on the client and how bad their kidney failure is what I would guess, and how strict they are with the diet. Now, if they're on the floor, I would imagine the diet would be pretty strict, but that would depend on how well it's being monitored.
Okay, thank you.
Let me see if I could just find you another answer. But if they're doing it daily there, they may be doing it daily at home too.
It's like a process is repeated multiple times and 7 days a week.
I do know that it like varies per patient, so
Yeah, I mean, some patients are really good with managing their diet. I think the more that they're in a facility, the more likely that's going to happen. We like for the patients that I used to deal with, but that was hemodialysis. We didn't do peritoneal. We would have days when they would cheat like that are close to their dialysis days. Not something they're going to ask you on the test, but it's a good question. And I will try to get a better answer from you. But I also would go with what my nurses on here are telling me because they're doing this on a routine basis. So they're seeing it being done and they're seeing what's happening out there real time.
Got it. Thank you. I was just curious because I see that one had a time frame, so I didn't want to get to the test and it says a time and I don't know a time. That's all. But I'll look into it and I'll take their advice as well. Thank you.
Yeah. So on the test, they might ask you about the hemodialysis, about how often that it is. They do sort of separate that out and say that. Most people that go to dialysis centers go every other day. But because the other one takes so long, but it does take things off slower, so that might be why they can do it for longer periods of time as well. All right, urinary tract infections. So you want to know about this, okay? Lower urinary tract is going to be cystitis, which is the bladder, and urethritis, which is going to be the urethra. And then upper urinary tract is pyelonephritis. Common causative organisms are going to be E. coli. So with pyelonephritis, that is inflammation of the kidney. I already told you about the other three. Prostatitis would be infection of the prostate gland. With both cystitis and urethritis, you're going to have pain in the pelvic area. So common symptoms for these are going to be dysuria, which is painful urination, urgency, frequency, and nocturia, which usually means nighttime. Systemic signs are fever, malaise, nausea, and increased white blood cells. The urine will be cloudy, usually has an odor. Now, make sure when you get your UA that you put it away right away. Because if you leave it sitting out on the counter, then there's no way for you to determine whether the bacteria came from sitting out or from the client. Pyuria, which is what?
In urine.
In the urine,
Okay. Bacteriuria is,
bacteria in the urine,
Bacteria in urine.
and
Microbes.
hematuria.
blood in
Blood.
the urine.
Okay. None of those things we want in the urine, by the way. Now, urethritis, there's two types. So, Miss Morgan did give you guys a good thing to remember, right? Gonococcal is from gonorrhea. Gonococcal urethritis, so gone and gone. Non-gonococcal is chlamydia. Most of the time. We'll look at some of the symptoms here, okay? So they're going to have a discharge with gonococcal or gonorrhea. That's going to be green. So it's gonococcal, gonorrhea, that's green. The 3G's got to go. The gonococcal, the gonorrhea, the green got to go. All right, the non-gonococcal chlamydia, it won't be as symptomatic. They'll have more of a mucus type of discharge. Or maybe none at all. Pyelonephritis. So here we can have either one or both of the kidneys involved. We have exudate that usually fills the pelvis and the calyces of the kidneys. This can be either a recurrent or a chronic infection, and it can lead to scar tissue in the kidneys, which we don't want because that's going to affect your kidney function over time. It can cause you to lose function of the tubules. Why is that a problem?
Protein and red blood cell counts or no reabsorption.
Okay, good. Because in the tubules is where reabsorption and filtration takes place. So we're going to lose that process if we lose the function of the tubules. Obstruction and collection of filtrate can lead to hydronephrosis. And if we don't treat it, they can end up with kidney failure. Okay, so classic symptoms are going to be pain in the lower back or the flank area. If they have a systemic infection, they'll have a high fever. Pain in the pelvic area, also common here, along with painful urination, urgency, frequency. And these will have urinary cast in the urine. Now, remember, what did we say is that in this pyelonephritis, those tubules are not working. And how do we know they're not working? Because those urinary casts are present. And that tells us that the tubules are involved or that there's damage there. Something's not working. All right, glomerulonephritis. Here, they'll usually have that anti-strep present. So you will do the ASO. It should be positive. This antigen antibody complex activates the complement system, and that causes an inflammatory response in the glomeruli. Now, remember, the glomeruli is where those nephrons are. That's going to be damaged. That allows increased capillary permeability. So those proteins and red blood cells that are not supposed to be in the urine are now going to go in there. Remember, with inflammation, right? We always see increased capillary permeability. We talked about that when we talked about the inflammatory response. They'll have congestion, cell proliferation, so rapid growth there, a decrease in the glomerular filtration rate, which is now causing them to hold on to fluid and wastes. So initially, we may see acute renal failure. If we don't treat it, it's going to lead to chronic renal failure. So again, if they're asking you about glomerulonephritis, what is the cause of it? So what's the cause?
Antigen antibody complex formation.
Okay, so they had that strep infection, that those antibodies are present, indicating they must have had some sort of infection that caused that antigen antibody complex to activate. That huge inflammatory response caused increased capillary permeability. So now things that are not supposed to leak is leaking, like protein and red blood cells or erythrocytes. We have a decrease in the glomerular filtration rate. Now we're retaining fluid, we're retaining waste. So what is that going to look like in the body? Urine is going to be dark and cloudy. The wastes are not leaving. They have facial and periorbital edema, generalized edema, elevated blood pressure. This is because now we have low flow or a decreased glomerular filtration rate. Okay, low flow. Now renin is going to be secreted. And that's going to elevate the blood pressure. Right? Because that's what it does. How is it going to elevate the blood pressure?
Renin secrete when blood flow is low.
But how's it going to elevate the blood pressure?
Secrete renin.
How's the renin going to elevate the blood pressure?
Aldosterone.
Angiotensin. Aldosterone.
Thank you. I'm going to keep asking you that.
Yeah.
Okay. So, okay, so you have to know the cause. So the cause is this anti-streptococcal antibody causing the antigen antibody complex, activating that complement system, that increased inflammatory response, causing that increased capillary permeability, causing that leak of protein and large number of red blood cells, causing congestion and rapid growth of these cells, decreasing the glomerular filtration rate, causing the body to hang on to fluid and waste. So now we have dark urine, that's cloudy, facial and periorbital edema, general edema, elevated blood pressure from increased renin and decreased glomerular filtration rate, back or flank pain, edema, stretching of the renal capsule, which is, again, is going to cause pain, decreased urine output. And the urine they are putting out is going to have protein and red blood cells in it. And remember, we have a decreased filtration rate again. Eventually, if we don't treat this, chronic renal failure. Okay, so what are some of the things that could cause this? Things like sore throat, pharyngitis, impetigo. And actually, I have a client that I took care of. He was 18 when he came to me. He was already in end stage renal failure. His dad severely beat him and his sister when they were about 7. The sister died. He was left with a strep infection, which he developed from the injuries from the beating. The strep infection was never treated, and he ended up in renal failure. So when I got him, he was 18 in chronic renal failure, end stage renal failure already. So think about how that affects somebody over time. But all this you see came to life that you see here. Okay. This is why it's so important that parents know when kids have certain infections, okay, they need treatment. They need to get in, they need to get seen. It's not just going to go away. So just make sure, you do, if you're working in peds, you're doing that teaching. All right, next is nephrotic syndrome. So with glomerulonephritis, okay, let me just get back to that slide over here. We saw that the urine was dark and cloudy. We saw that it started with facial and periorbital edema. Here we see proteinuria. So we are going to have that protein in the urine. We see lipiduria. Why? Because they have a really high level of cholesterol and lipids. And the lipids cause it to have a milky appearance. We'll have massive edema as opposed to just starting with that facial and periorbital. And we'll have a sudden increase in the girth here. So that's how you're separating out one versus the other. Now let's look at nephrotic syndrome. So here we have abnormality in the glomerular capillaries causing an increased permeability. So that's allowing the proteins to get into the urine. They don't really know why. It happens to kids between the ages of 2 and 6. Things that could cause it are systemic lupus erythematosus, exposure to nephrotoxins, or drugs. Wait a minute, Miss Sue. These are kids 2 to 6. So how are they exposed to nephrotoxins? So think about a kid that's young that has infections. What do we give them for those infections?
Antibiotics.
Okay, what are some of those infections that they get? Or some of those antibiotics that we're treating with? I'm sorry. Anybody know?
Gematizing.
So how about mycins?
Mm-hmm.
Yes.
Gentamicin.
Yeah. Yeah.
We give a lot of that to kids, right?
Yes.
Yes.
My rhyme for mycins is mycins never let you win. They're toxic to the kidneys and the hearing. These kids can lose kidney function or have their kidneys damaged if we're not careful when we're giving them antibiotics. Okay. Certain chemo drugs that they might receive could be toxic to their kidneys because usually if we're going to see something like this, the kid's probably going through some other things. All right. But not necessarily. They could just have a strep infection and it could lead to this. But typically, these kids are going through some other things. So that's why a lot of times you'll see this if you're working at a place like CHOP or someplace like that. Sometimes they'll come home too, like this. All right. So, idiopathic in kids 2 to 6, because they're going to ask you what causes the nephrotic syndrome. But it could be because of some exposure to SLE, systemic lupus erythematosus, which is autoimmune. By the way, that also causes deposits into the organs. Hypoalbuminemia. Okay, why would they have that?
Protein is in the filtrate.
Okay, protein's being lost in the urine, and it's primarily albumin. Remember that albumin controls what?
As oncotic osmotic pressure.
Osmotic pressure. Albumin and sodium are maintaining that osmotic pressure. So now, because the albumin is not maintaining that pressure, we have generalized edema. So it's throughout the whole body here, guys. That's why we measure the girth. We have that sudden increase in the girth. The blood pressure here will remain low or normal. Remember in glomerulonephritis, how's the blood pressure going to be?
It's low.
High. Glomerulonephritis, the blood pressure will be high.
Because of renin.
Because of the renin being triggered because of the decreased GFR.
Yeah, that's
okay. Here, the blood pressure is going to be either low or normal. They will secrete aldosterone in response to the reduced blood volume, and that can lead to more severe edema. And then they have high cholesterol levels. So we'll see that protein in the urine, that lipoprotein in the urine, that lipiduria, that milky appearance. Those are the differences you need to know. Okay, as you get older, what's going to happen to those kidneys? All right, so we have a decrease in the number of nephrons. Our renal flow, our glomerular filtration rate will also decrease. That's going to cause a little bit of atrophy there. Okay, so they're losing some of that kidney function. And how's that going to affect them? Okay, because the body needs those things in order to help maintain the pH and in order to help maintain the fluid balance. So kidneys have to work harder here in order to compensate. All right, hydronephrosis. You have to know this. So usually this is caused by things like calculi, which are stones, tumors, or scar tissue. Now, scar tissue can come from a variety of reasons. Lack of blood supply, and obstruction, infections, untreated prostatic enlargement. So prostate gland is getting large and we're not doing anything about it. We're ignoring it. Developmental abnormalities, those can restrict the urine flow. A lot of these clients will be asymptomatic in the beginning, okay? But if we don't remove the cause, then they can end up in chronic renal failure. So what eventually happens is the callus becomes distended, the pelvis becomes distended, the ureter's blocked there, and it backs up behind the kidney. Renal cancer. So we have the primary tumor arising from the tubular epithelium, happens more often in the renal cortex. These clients will be symptomatic early on. It can metastasize to other parts of the body. Kidney cancer is going to happen more often in those people that smoke and in men. And then look at the manifestations. So blood in the urine initially, and there's no pain. What does it mean by gross or microscopic?
Microscopic is, you mean,
Cellular.
with the naked eye, and gross is a lot.
Okay. Dull, aching flank pain. That's usually going to be right at the back, right around where those kidneys are. A palpable mass, so sometimes you might feel something in there. Unexplained weight loss. Why anemia?
Erythropoietin produce erythrocytes. So kidney, if not working, the erythropoietin does not
Good,
produce the erythrocyte, and it's anemia.
good. Exactly right. Okay. Paraneoplastic syndrome. What's that?
Is B12.
So remember, that's when you have a tumor that is producing hormones, okay? And it's causing things to happen in the body. So, like Cushing's syndrome, because maybe the tumor is producing too much cortisol. Hypercalcemia, they can retain calcium here, and that calcium, when retained, is going to cause problems, right? Moans, groans, kidney stones. So it causes pain, bone pain mostly, kidney stones, constipation, mental issues, confusion. And with hypercalcemia, they can actually develop pathological fractures if it gets severe enough. Cushing's syndrome is what?
Is a cortisol, too much cortisol.
Okay, so they have that round moon-like face, that buffalo hump. All right, so what would put you at risk? And I would know this. Working with chemicals in the lab and industry. Remember, I talked about my uncle working at Goodyear Tire. This is what they make, rubber tires. They use dyes, they use chemicals to make those tires. Recurrent infections, cigarette smoking. So he worked in the Goodyear factory with the rubber, the tire, the dyes, and smoked cigarettes. Again, signs: hematuria, painful urination, infection. All right, urethrolysis. This can be calculi or kidney stones. These are a common problem, and they'll frequently reoccur if we don't treat the cause. The problem is the stones can cause symptoms if they block the flow of the urine. So it'd be that colicky pain we know about. The calculi can cause infection because it doesn't allow the urine to move. So the urine sits there and bacteria can grow. When it's in the kidney or the ureter, it can cause hydronephrosis. That can cause the calluses to dilate. It can cause atrophy of the tissue because of the back pressure of the urine behind the obstruction. So that excessive pressure is can cause a lot of damage. The stones are made from phosphate, oxalate, or carbonate. And they form because the calcium levels of the urine are high, or because maybe the person has too much calcium in the body from like a parathyroid tumor or some sort of metabolic issue. The stones are easily able to form when the alkalinity in the urine is high. Inadequate fluid intake is a major cause of stone formation. Calcium oxalate stones can develop in relation to vegetarian diets when they eat foods that are high in oxalate. Okay, so that can be things like iced tea, things like spinach. Those can increase your levels of oxalate. Any questions on any of that? All right, hydronephrosis usually happens as a secondary problem. Okay, because of calculi, but it also could be from tumors, scar tissue, ureters, untreated prosthetic enlargement, some sort of developmental issue causing some sort of kinking or stenosis of the ureter. Any prolonged interference with urine outflow causes back pressure, dilation in the area. It'll be filled with urine in the ureter or the kidney. This causes a buildup of urine, especially over a prolonged period. That causes necrosis of the tissue because of the pressure and because of the compression of the blood vessels. A lot of times this will be asymptomatic. If they do have pain, it'll be mild flank pain because the capsule of the kidney itself is stretching. Or sometimes they'll have pain if they develop an infection. If we don't remove the cause, then it goes to kidney failure. Nephrosclerosis. So again, what's the patho? Here we're having changes in the vessel. So like in arterial sclerosis, the vessel becomes sclerosed, which means it's going to be hard. It can't get as much flow through it. Some of these changes are going to happen because you're getting older. Excessive changes will cause thickening and hardening of the walls, and that causes narrowing and occlusion of the lumina. Sudden changes will reduce the flow of blood into the kidney. That will cause ischemia, atrophy, and cause the stimulation of renin. So now renin's released. What's going to happen?
High blood pressure.
High blood pressure. Okay. So look at number 1. We have hypertension. That causes a decrease in the blood flow to the nephrons. That stimulates the renin. That renin and aldosterone cause systemic vasoconstriction and an increase in the reabsorption of sodium and water. That is going to increase the blood volume, which increases the blood pressure, which causes hypertension, which causes you to decrease the blood flow to the nephrons. So you see that vicious cycle. The hypertension itself causes more damage to the kidneys. And because it's the vessels that are in the kidneys, it's called nephrosclerosis. Eventually, because you have this decrease in blood flow to the nephrons, okay, that interference with the blood flow leads to ischemia, necrosis, and fibrosis in that kidney, causing atrophy of the kidney, and over time, they're going to develop chronic renal failure. Any questions on that? This is that dangerous cycle they're talking about. Polycystic kidney. That's what it'll look like right there on the right. This is caused by chromosome 16. Usually happens after 40. Multiple cysts on the kidneys. They're going to end up in kidney failure. Okay, because it causes enlargement of the kidneys, it compresses and destroys the tissue. So, cause autosomal dominant gene on chromosome 16. What are we going to see? Cysts developing in the kidneys, enlargement of the kidneys, compression and destruction of the kidney, leading to chronic renal failure. Wilms tumor, usually diagnosed around age 3 to 4. We'll see a large abdominal mass that now becomes obvious. Usually they can't fasten their clothes. Sometimes they develop high blood pressure. Usually when you see this on the nursing test questions, but for this class, they'll probably ask you the cause. So look at the cause there. What is it? Abnormal chromosome and congenital renal abnormalities. So usually they're born with this. But it's not obvious until they become about 3 or 4 years old. Or maybe in some cases they get that high blood pressure, but usually you'll see the abdominal mass or you'll have problems closing the waistband first. Because we don't usually do blood pressures on kids. Acute renal failure. This can be caused by bilateral kidney disease. Shock is a major cause of this. Stress can cause this. Because stress causes what?
Cortisol, the high blood pressure.
Vasoconstriction, right? Because stress triggers what?
The sympathetic nervous system.
Okay. And when the sympathetic nervous system is triggered, what's going to happen to blood flow to the kidneys?
Constricted.
Gonna decrease.
Decrease.
Vasoconstriction. Okay, so severe prolonged stress, dehydration, circulatory shock, heart failure can lead to this. Nephrotoxins, okay, again, those mycins, whether you're adult or kids. What do we give adults? Vancomycin, streptomycin, gentamicin. Mycins never let you in, toxic to your kidneys and your hearing. What else? Those chemo drugs. And there's a lot of other drugs, even furosemide. If you're not giving it right, it could be toxic. Mechanical obstructions. Things like calculi, blood clots, or tumors. Or the urine is blocked. All right, so usually this will be of sudden onset. We'll do blood tests. We'll see that elevated BUN and creatinine. Remember I said BUN and creatinine are your main markers for urinary function. So you're looking at those. Those are going to be elevated because the body's not getting rid of it. Acidosis. Your kidneys cannot get rid of acids when it's failing. And acidosis and hyperkalemia go together. It also cannot excrete potassium when it's failing. Chronic renal failure. What are causes of it? So, gradual, irreversible destruction of the kidneys over a long period of time. It's usually asymptomatic. Some things that could cause it: chronic kidney disease, congenital polycystic kidney caused by what chromosome?
Chromosome 16,
16.
After the age of
40.
Okay. Systemic disorders, low level exposure to nephrotoxins over time. Maybe you worked at a job where OSHA wasn't followed, and whatever you were exposed to, okay, or you were taking something, some kind of drug, over a long period of time. Like when you do Venco, okay, how many of you have ever given IV Venco?
Yes.
We do peaks and troughs on that. Why?
To monitor it, make sure it's not causing damage.
Exactly. So we have to monitor those levels to make sure the body is excreting it. Otherwise, we'll kill those kidneys. So we do peaks and troughs. The peak is going to tell us, like, we'll give the medication, we'll check the peak a certain amount of time afterwards to make sure it's going up to the proper level and not too high. And then at the end, before we start that new dose. End stage renal failure, your glomerular filtration rate is negligible. What's that mean?
It's not working.
Yeah, you're not getting anything out. So your body is holding on to fluids, electrolytes, and waste. Azotemia is what?
Waste, nitrogen, urea, waste.
Okay, good. Your blood is toxic now with nitrate wastes. Anemia is what?
Lack of red blood cells.
Okay, and those red blood cells are usually microcytic. They're lacking color. Acidosis. Why do we have acidosis here?
Kidney cannot work, so hydrogen ion does not remove.
Okay, kidneys can't get rid of those hydrogen ions, and that's causing us to retain acid. And what's going to go along with that acidosis?
Metabolic.
What can't they get rid of also? What else does the kidneys excrete?
Is it sodium?
Potassium.
Potassium. Okay, so they'll have marked oliguria. What does that mean? Or anuria.
Little, no urine.
Okay, little or no urine output. They're going to need dialysis, and they're going to need that first because kidney transplants don't happen overnight unless they're extremely blessed. Like a kidney was going to somebody else and it wasn't going to make it there, and all of a sudden this patient was a match and got it. Otherwise, you're on the list for years for kidneys. So we'll have a decrease in the glomerular filtration rate. And again, it's negligible. So it's not removing anything or very little. Creatinine is going to go up because now you're retaining waste in the body. A lot of times they don't have clinical signs. They'll get rid of, in early stages, large volumes of dilute urine. They'll have a decrease in the production of erythropoietin. Why?
Cannot.
What do the kidneys do?
Kidney cannot work, so erythropoietin does not produce the erythrocyte.
Exactly. The kidneys produce erythropoietin,
Yes.
right? So they're not going to be able to here. Blood pressure is elevated. Why?
Renin.
Kidneys aren't working. We have low flow coming in. That low flow is going to stimulate what?
Aldosterone. Aldo.
Renin first, right?
Yes, I told renin.
going to stimulate renin first. That high blood pressure is going to decrease the blood flow to the nephrons, right?
Yes.
When that high blood pressure decreases the blood flow to the nephrons, that's going to stimulate the renin. That's going to cause vasoconstriction. It's going to cause release of aldosterone, which is going to cause us to hold more sodium and water. That's going to increase the blood pressure, which is going to then stimulate low flow to the nephrons, which is going to release more renin. Vicious cycle here. What causes it? Look at our main things here, guys. Diabetes, high blood pressure, heart conditions, obesity, stroke, because, again, those vessels are being blocked. Genetics, family history, smoking cigarettes till dawn, and being over the age of 60, because now we have a decrease in the kidney function starting at around that age. So early signs versus late, I would know them. Initially, you're going to have a lot of urine out, but it's very dilute because the body is not reabsorbing, is not excreting the stuff that it needs to, okay? So that's why it's dilute and a lot amount. The body is not filtering the way it's supposed to. And that's the issue there, okay? So these clients initially will have anorexia, nausea, anemia. We talked about anemia. Why? Because the kidneys aren't producing those red blood cells. Fatigue. Again, that goes back to your anemia, and it goes to your azotemia. Because if you have all that toxin in your blood, that's not going to make you feel good either. Unintended weight loss, okay? That has to do with the anorexia, the nausea. Exercise intolerance. If you have anemia, you're going to have that. And elevated blood pressure. We just talked about the vicious cycle of that, right?
Mhm.
All right. Once the kidneys completely fell, now you're going to have oliguria, so no urine output or very low. Because you're holding on to all those wastes, you're going to have skin that's dry, itchy. It bruises easily. Neuropathy. Again, that can go back to that vitamin D. You need vitamin D to help with that leg function, those nerves. Impotency in men and menstrual irregularities in women. Encephalopathy. This is in the brain. The body's not breaking down the waste. So now your brain is going to be affected. Congestive heart failure, fluid overload, failure to activate vitamin D, uremic frost on the skin, and systemic infections. So know the difference, okay, between the causes, the signs, and symptoms of early versus late. And that's for chronic renal failure. Now, this page here is showing you some of the differences between the causes of acute versus chronic, the onset, what it's going to look like. All things we just talked about. Any questions on any of that? So causes are your patho. That's what caused it, your pathophysiology. Signs and symptoms. That's your focus for this course. All right, what time we got here? 11 o'clock. That's going to be it for today, guys. I do have a tutoring already online that I put on you for reproductive, so you should be able to look at that. All right, and we'll go over some of this stuff next week, reproductive and some of the other stuff. Okay.
Thank you,
Miss
Thank you.
Loesch.
Have a good one.
All right. Take care.
Miss Loesch,
Yes.
Sahara.
Okay, hold on.
Again.
I'm gonna put you in a
Okay.
breakout room. Just hold on.
Okay.